Can we start, Puneet? Okay, so good evening. Welcome to this session, which normally we do every week, in which we try to capture common questions which are in the mind of the students and many frequently asked questions which they are asking in the Telegram app. We will like to take those questions. And I'm so happy that we had wonderful discussion with all the faculty members of this week. And this week is a newborn week. You all know that, which has. Why it is coming again? In newborn week, also we are concerned that we need to take care of premature babies which are born below 37 weeks of gestational age. They account for like 13% of the births which take place in India. And we wish to provide them quality care. And week 2 has focused on delivery room care, golden hour management for preterm babies. And also, if you have to transport a baby, how do you do safe transport after stabilization? So, may I ask Shashidhar to make a small presentation, and then we'll take question answer, which all the panelists can answer. Shashi.
Yeah. Thank you, sir. So, next 7-8 minutes, I think would be to take you through whatever you learned so far in a nutshell. Just to give a context for the discussion, whatever we have learned in the last 6 to 7 days. So initially we learned that newborn deaths, almost 35% of them are preterm. That is our focus. And also 20 deaths are due to asphyxia. And if you take the both together, that means preterm with asphyxia, especially in the first 1 hour of life, becomes a priority area for management if you want to prevent newborn deaths. So this is a focus, and that aspect is called the golden hour. That is, preterm infants are at high risk of asphyxia, and also there are other concerns for a preterm in labor room, like hypothermia, which we dealt with the last week, breathing difficulty, which we are going to deal with in the next few weeks, hypovolemia and hypoglycemia. We also learned that TABC is the cornerstone for management. Temperature, starting with temperature. So the whole week, the last week was all about temperature. This week we concentrated on a little bit of airway, breathing and circulation. If you see a pyramid, all newborn babies require some sort of assessment and provision of warmth at birth. Very few of them, about 5 to 10%, require initial steps, that is suctioning, stimulation, position, reposition. Very few of them require positive pressure ventilation, and hardly less than 1% of babies, or 1 in 1,000 babies, require chest compression and extensive resuscitation. So our focus as primary workers on the field should be to take care of this bottom part of the pyramid, especially assessment at birth, warmth, initial steps, and positive pressure ventilation. But we also should know and should be able to assist in chest compression and administration of drugs. So what actually does it entail? TABC, the temperature we have discussed extensively, mostly about room temperature of the delivery room, 26 to 28 degrees, and simple innovative steps like plastic wrap or a polythene wrap, airway, provision of suction catheters, breathing, laryngoscope and umbilical venous catheter, also a normal saline. But it's very probably easy to get all this, but we need at least 2 qualified people to attend each delivery. And it's difficult to remember what in all the labor rooms, which is checked every day as part of inventory, so that nothing goes missing. And especially for preterm babies, we need plastic wraps, which are easily available. We had an extensive discussion of all this. And blender and TP's resuscitator, which you can see in this picture. But mostly, what we forget is that resuscitation in the delivery room is teamwork. And we know everybody, and we are also learning. So, a part of teamwork, which was also emphasized in the previous webinars. We also understood that self-inflating bag, the use of self-inflating bag is probably the most important step, because ventilation is the ultimate lifesaver for a newborn baby. We know the parts of the bag, we know how to give, we know what is the pace, 40 to 60 breaths per minute. We should know what is the rhythm, breathes 2, 3, breathes 2, 3, and all that. We also were introduced to a new equipment, that is the oxygen air blender, to prevent hyperoxia ice. So this is where we set the FiO2 for a newborn baby who is a term baby, which is 21. For a preterm baby less than 31 weeks, probably it will be 21 to 30%. So we need this also, as if our delivery and management is going to be optimal. We also learned that provision of a TP's resuscitator, if you have, it's very good, because it is set pressure we can deliver, PIP, PEEP, and it works without electricity. It can be used as a transport ventilator also, and most importantly, it gives CPAP. So we should be always trying to get this TP's resuscitator into our labor rooms whenever it is possible. And the other equipment, which was only in the NICU, now it's making its way to delivery room also, is the pulse oximeter. And pulse oximeter should be connected for all preterm babies who require some positive pressure ventilation to be monitoring saturations of preductal limb, that is right upper limb. And the rising heart rate is the earliest and best indicator for effective resuscitation. So I'll just take you through the resuscitation algorithm. That is, before birth, we need skilled people, equipments, and we need to talk to parents. And at birth, we ask questions, like only one question, that is whether the baby is breathing or crying. If the baby is breathing and or crying, we don't need to separate the baby and the mother. So that is zero separation policy. Baby stays with the mother, gets cord clamp after 1 minute, gets the skin to skin care, which is warm, and initiates breastfeeding within 1 hour. If the baby is not crying, then only the baby is separated from the mother, taken to the radiant warmer, and monitored for respiratory distress and respiratory efforts. If the baby doesn't have respiratory efforts or the heart rate is less than 100, then we need to give positive pressure ventilation. And this positive pressure ventilation should be checked after a few breaths whether heart rate is rising or not. If the heart rate is rising, then we continue positive pressure ventilation for 30 seconds, then reassess the baby. If the heart rate drops, which is very rare, then we may need to check if the positive pressure ventilation is effective or not by looking at MRSOPA, Mr. SOPA, mask, reposition, suction, open mouth, increase the pressure, and lastly, alternate airway like an intubation or LMA. We also got to know about chest compressions. If the heart rate is less than 60, also about post-resuscitation care after doing positive pressure ventilation for more than a minute, which includes NICU care, and we all know the components of post-resuscitation care. So the main reason why I put this is, this should not be learned when you are attending deliveries. They should be part of muscle memory or spinal memory. And even if you're attending delivery at any odd hour like 12 a.m. at night, the flow should be ready with you. And chest compression is always a two-person's job. And even in chest compression, we know ventilation is the primary focus of newborn resuscitation. Very rarely does a baby need umbilical catheterization with an umbilical vein to give volume. And we all discussed about insertion of an orogastric tube or a nasogastric tube and how to measure and how to check. We all enthusiastically answered of how to check whether it is in place. There were a few questions about delayed cord clamping, which is actually physiological cord clamping. That is not cutting the cord unphysiologically before the baby starts breathing. And we discussed very many benefits of this delayed cord clamping in preterm babies, like prevention of IVH, stabilization of blood pressure, prevention of MEC, but most importantly, it prevents in-hospital mortality in preterm babies. So we all need to encourage delayed cord clamping for all those babies who cry at birth. And also skin-to-skin contact. Not only it improves temperature, but also it improves blood sugar levels in the newborns, and also it has a long-lasting impact on breastfeeding rates. So people who got skin-to-skin contact, those babies breastfed about 2 months more than other babies. Lastly, we were also taught about triaging and transport. And whenever a sick newborn comes to you, that baby needs to get emergency care, and those are called emergency, priority, and non-urgent, so that our resources can be focused to those babies who require the most. So we know all the cases which classify as emergency. And we also got to know two mnemonics to remember when we are transporting a baby from one center to the other. Those are stable and TOPS. Stable, sugar, temperature, airway and breathing, blood pressure, and laboratory work and emotional support. TOPS is temperature, oxygenation, perfusion, and sugar. So these are few simple things to remember what all you need to do before you transport a baby. So as part of golden hour management, we are focused on hypothermia, we are focused on hypothermia, we are focused on delayed cord clamping, we focused a little bit on stabilization of respiratory and cardiovascular system, targeting saturations, using TP's resuscitator, antenatal counseling, etc. So overall, in the 1 hour, which is called the golden hour after the baby's birth, we need to make sure that the baby transitions well from intrauterine to extrauterine life. I would like to thank Devari sir and Dr. Lalan sir and all my friends in the second week for such a wonderful discussion, and for all of you also who enthusiastically participated and are participating now.
So thank you, Shashidhar, summarizing what all was taught in week 2. There are few questions which many of the participants were asking very frequently. So let me ask Suksham to reply to one of the questions, which is, Suksham, question was, why do we put the pulse oximeter on the right hand? Suksham?
Myself?
Yeah. We say we should put the pulse oximeter probe on the right hand.
So why we are putting it on the right hand is the question. So when the baby is in utero, it's a parallel circulation. So but once the baby comes out of the mother, the circulation, the established circulation, the preductal is maximum at this time is given by the right hand. Although in first 24 hours, a bit of it may be given even by the left hand, but we always go by the one which is more reliable, and the most reliable being the right hand. So we prepare in advance only that we have to apply it in the right hand by cleaning it and by keeping all the things ready for it. Say 2 stickings, and these stickings are being, or if you have some wraps are also coming now with the pulse oximeter. If you have the wraps, it's okay. Otherwise, you can prepare 2 stickings in advance so that all this time is saved, and you have a gauze also to clean the right hand.
Good. Yeah. So you put on the right hand because many times the ductus is open. So the right side is going to give you the true saturation in the baby. And that is the reason, as Suksham is explaining, we should put on the right hand. One more question, Shashidhar. A lot of people are asking that the cling wrap which we use, how it has to be sterilized. In your unit, what do you do?
We don't, I mean, once we get it from the store, usually it's easily available in food stores or supermarkets. So once we get it, we actually sterilize with gas sterilization, and we use it only once. So it is for each baby. So we wrap it, then we cut it, and then we don't use it again and we dispose it.
And
So,
yeah.
yes.
Suksham, how do you sterilize them? Cling wrap. Suksham?
Now, sir, we don't sterilize them. We use the cling wrap. And one another thing, you can correct me if I'm not right. At times, if the cling wrap is not available in all the every room, there are sheets which are available for mother. These are all disposable ones. And if it is not available, cling wrap is not available, then we use even that. These are all disposable plastic sheets which they are using for the mother when the mother is being laid down on the delivery table.
Okay.
And these are one-time use and throw sheets only, whether it's cling wrap or these sheets.
Thank you. I'm very sure most of the people are doing this way only in their units. And Rashna, there is one question for you that while you do Mr. Sopa, there is a question, what is pressure increase in Mr. Sopa?
I think that's a very good question. Whenever we are giving bag and mask ventilation, then what happens is we always teach not to apply too much pressure. We should just use 3 fingers and apply pressure so that the chest just is seen to rise. Because if you give too much pressure, then there is a chance of pneumothorax. But when you're having a chest rise which is not occurring because of various reasons, it could be obstruction. It also could be because the lungs are stiff. In that situation, then what happens after we have done the mask repositioning, the section, then we will again give a little bit more pressure and try to raise make the chest rise. So if there is a stiff lung, then you will just increase a little bit of pressure when you are giving the breath in the bag and mask.
Yeah, thank you.
Is that,
yeah, thank you. I think it explains. Once you have taken corrective steps, then you increase the pressure because your aim is to move the chest of the baby. If chest is not moving, you are not doing effective ventilation on the baby. Okay, so that message should be carried by all people who are doing resuscitation of newborn baby in the delivery room. Shashidhar, one more question for you. At what time do you put orogastric tube while you are doing resuscitation?
Whenever the baby requires, yes, sir. Whenever the baby requires prolonged bag and mask ventilation. So this prolonged bag and mask ventilation is not defined. So we usually take it as 2 minutes. If you are doing only bag and mask ventilation, you are also inflating the stomach. And when you are inflating the stomach, it can impede ventilation if the diaphragm rises up. So just to vent this, we need to put orogastric tube. If you are already intubated before two cycles or 2 minutes of bag and mask ventilation, there may be no need. But it's essential when you are resuscitating a CDH baby, when you don't want the diaphragm to and bowels to get. So any time when there is prolonged bag and mask ventilation, you put orogastric tube.
So again, I think Shashidhar is correct. Previous edition of NRP book used to say, if you are doing bag and mask ventilation for more than 2 minutes, it is always advisable to briefly disconnect and put a orogastric tube and leave the other end of the tube open so that whatever air gets into the stomach will not press over the diaphragm. Okay, but it is very important for a patient with diaphragmatic hernia because you want to decompress all the air which is there on the left side also. So in diaphragmatic hernia, bag and mask is contraindicated. If you have to give oxygen to the baby, you have to do intubation and put a orogastric tube so as to decompress all the air from the stomach and the intestine, which is there on the left side. Because 90% of the time, the diaphragmatic hernia is on the left side. Dr. Seema is from Himachal, Tanda Medical College. Seema, are you around?
Yes, sir. Yes, sir. Good afternoon, sir.
Yeah, can we see your video also?
Yes, sir.
Because Himachal is very cold, and I heard it is snowfall is there or not at this time?
Yes,
None. So Seema, can you again summarize why we need to do delayed cord cutting in newborn babies, especially who are preterm 1, 2, 3, 4? What are the reasons we need to do delayed cord clamping?
The major factor is to prevent anemia basically. Like when we cut the cord, sir has already explained it. Preterms are basically they are prone to get anemia of prematurity. When we cut the cord, physiological delay is there, and basically we are pumping the blood, extra blood during the delivery itself. We are like adding to them, and that's of course like we can prevent anemia. That's the first factor.
Yeah, so World Health Organization recommends we should delay the cord cutting for 1 to 3 minutes, and the reason for that is the baby will get more blood. Risk of anemia in the baby
Yes,
at
sir.
6 months is going to be less. Second is, as Shashidhar said, it stabilizes the baby much earlier. The blood sugars are going to be normal in the baby, and in a preterm baby,
Yes,
the
sir.
risk of NEC and IVH is reduced by 40% because there are Cochrane which are done. So delayed cord clamping in preterm baby has multiple benefits. We have to promote that and need to take our obstetricians on board or people who are in the delivery room, because unless they are convinced, they will not follow it. And it is very hard to convince the obstetrician and other colleagues that delayed cord clamping has to be done. And how do you get it done? You have to have a clock with big clock with seconds you can see, and then you say loud that now it is more than 1 minute or more than 2 minutes, then they can cut the cord. Okay, so that has to be conveyed to the obstetrician. Very important.
QA project, sir.
It is just like a QI project. Suksham, let me ask from you that in Chandigarh, in your hospital GMC at Chandigarh, do you do immediate skin to skin care for the babies?
Sir, we do immediate skin to skin care for the babies who are born only by vaginal delivery. And these we
Okay.
have the delivery table of mother is slightly bigger. It is more in width, so that even obstetrician is at comfort. Most of the times when we inquired why aren't they doing, the reply was that their fear says the trolley is narrow and the baby may not slip. So we change these trolleys of the mothers where they are delivering the delivery table, and obviously the way just Shashidhar and you pointed out, it's a QI project. So when it was less, we looked into the causes, what are the reasons, and they were also correct in their apprehensions. Those corrective measures taken, and then skin to skin contact. A long back we started say around I think now 14-15 years, but in between it decreases, and then it has to be again picked up by the QI and finding out what are their apprehensions.
Yeah, so I think while you want to do immediate skin to skin contact with the baby and the mother, many times you need a birth companion who has to stand there, or maybe a nurse has to stand there to make sure that all safety measures are taken. Otherwise, the baby may slip down also, and the mother may be sometimes after delivery, she may be dizzy and not able to hold the baby correctly. So keep that in mind. So if we are following immediate skin to skin care, companion or a nurse or someone else has to support that mother for doing immediate skin to skin care. Seema, there is another one question. Will delayed cord clamping lead to increased risk of jaundice in that preterm baby? Seema?
Sir, the recent publications, they have said no.
Yeah. So
Recent literature is saying no to this. Yes.
yeah, so the evidence shows that maybe slight increase in the bilirubin levels are there, but these babies don't land up in like higher rates of exchange blood transfusion or very high levels of bilirubin. So the advantage which we get by delayed cord clamping outweigh the risk of having little bit higher jaundice in these babies. Okay, so it is very safe. So we need to all promote doing. I think everyone must remember that all babies, whether they are term or preterm, all babies require essential newborn care. And the package of essential newborn care, in addition to taking care of resuscitation, also includes taking care of temperature, giving vitamin K to the baby, then weighing the baby also is a part of that, and then making sure that the baby is kept close to the mother, and early initiation of breastfeeding is done even in a preterm baby. If baby doesn't require resuscitation and you are doing skin to skin care, so early initiation of breastfeeding has to be done. So I hope, Divya, it answers your question. There is another question by Jaya that Shashidhar, how do you know at the time of birth that the baby has congenital heart disease, and whether it may have consequences of oxygenation and doing intubation on the baby?
Initially, I think it's very difficult to know, and the labor room in 1 hour that the baby, to diagnose the baby having congenital heart disease or not. And any problem in the labor room, we assume it to be respiratory. That's why ventilation is the priority, is the mainstay of newborn resuscitation. Having said that, if you have a good ultrasound scan, some of them can pick up this cyanotic congenital heart diseases. Or secondly, if there is increased oxygen requirement, even after ventilation, the baby is not maintaining saturation. The saturation targets which you saw are not met, and even if you give 100% oxygen, there is no improvement. Then you may suspect. So one is hypoxia, cyanosis persisting even after good ventilation and giving good oxygenation. So that's the only clue which you have. And the other clues may be in the scans, polyhydramnios or 2D echo, fetal echo. If it is done, then you may find. But it's not a priority to diagnose a CCHD in the labor room. You need to go as per NRP algorithm, even if you know that the baby may or may not have CCHD, and get the baby to ICU, stabilize, and get a good echo or ECG and X-ray for evaluation of CCHD later on.
So I think if you have an echo and previous diagnosis which is made, it helps you in taking right decisions during the time of resuscitation. But as such, congenital heart disease, which is cyanotic and drug dependent, it is there, but it is not incidence is not so high. But the management in the delivery room stays the same as you are providing to all babies during the golden hour. So one more question which goes to now Rashna. Are you around, Rashna Das?
Yes, sir.
Okay, so there is one question by Dr. Alauddin. He has asked, if a baby has tracheal atresia, which is diagnosed antenatally, how the resuscitation is different as compared to the other babies. Tracheal atresia.
I think, sir, if it's a very rare condition.
Very, very rare, yeah.
Very, very rare. I haven't seen any till now. We usually get tracheoesophageal problems, but tracheal atresia per se I have not faced till now. But if there is a problem like that, then obviously this baby is not going to respond to the bag and mask ventilation or even intubation. So we would need an emergency tracheostomy or something of that sort in this child, in this newborn baby. So I think the only way we'll come to know is that there is no response to bag and mask ventilation, and maybe there is difficult intubation.
Yeah, so
This is a surgical
the choice is there to do emergency tracheostomy in a baby who has got tracheal agenesis or atresia, because such babies you will not be able to intubate and they will not improve in the delivery room. So if you know the antenatal diagnosis, then best is to do emergency tracheostomy. You have to have the ENT person also joining you at the time of doing resuscitation if you are not confident in doing it. We have seen babies who are born with tracheal like atresia and agenesis, and we have successfully managed also such babies by doing tracheostomy, and later on the tracheostomy also was closed. So it's a very, very rare condition. It is not so common. I've not understood this question. One question is asked by Ruma. For a patient who has got congenital heart disease, can oxygen be given by hood? Shashidhar, in the chat box, if you read, I'm unable to make out what this question is. Okay.
I think that's a different question, sir. Can oxygen be given by hood is a separate question.
Okay, maybe a separate question. Yeah.
So,
yes. Yeah. Please
yeah.
go ahead. Go ahead.
Yeah. Oxygen definitely can be given by hood, but the only thing is you have to make sure that you give a good flow rate, at least minimum of 4 to 5 liters per minute, so that you don't have carbon dioxide buildup, and it wastes a little bit of oxygen. So you need a lot of oxygen stores. So we would probably prefer to give by cannula and give very low flow rate. But at the same time, make sure that your nose and everything else is protected.
So I think oxygen hoods can be used for giving oxygen. Only thing is, remember, it may lead to a lot of wastage of oxygen. But if you have cannula which are appropriate size, which can be fitted, then it will be better. If you have a pulse oximeter, you can titrate the flow against how much has to be given with the help of cannula. Okay, so this again can be a quality improvement project. You can identify that you want to reduce the usage of oxygen, which is wastage of oxygen in your unit. Can you do it if you shift from your oxygen hood to nasal cannula? Okay, but you will have to do monitoring on the baby. So, good question. So I don't see other questions in the chat box or on the YouTube link, and majority of the questions have been answered by the faculty members while they were interacting with all the participants. There will be live YouTube link which is embedded on the Telegram app. Whatever we have discussed, people can click it and then they can listen to what has been discussed today in the last 30-35 minutes. So I am grateful to all of you for taking your time and interacting with the students. I think is a great learning both ways, for the teachers also, for the students. And thank you, Rashna, Seema.
So there's one more question in the chat box.
Yes. What is the question? Please say.
Delayed
Rashna.
cry, is it defined by a time? How do you say is delayed cry? Is it defined by a certain time? I think what the participant wants to know is there a time limit by which the baby should cry?
Very intelligent question. So, Shashidhar, what is the answer for this? You have to see, while you are doing initial step and you are wiping the baby and drying the baby, if baby is not crying at that point also, then you say it is delayed. So it is that decision will happen within a period of 15 seconds. Shashidhar.
Yes, sir. So I think that's a good question, which is difficult to answer. But I think we take breathing and crying as the same. So even if the baby does not breathe, does not cry at birth, it's okay as long as there is breathing movements.
Yeah.
So you have to make sure that the baby is breathing as soon as the baby is born and completely out of the mother's uterus. So if the baby is not crying, so you have to make a decision there as soon as the baby is out. Baby is not breathing or not crying, clamp the cord, cut and then take the baby for initial steps. So the decision is to be made, I don't know, within 5 seconds or so. So there is no definition for delayed cry, but we go by breathing efforts rather than the audio effect of cry.
And see, while you are doing immediate skin to skin care, also, you will put the baby on mother's abdomen. You will use a towel to clean the baby. And during that period, you will come to know whether a baby is breathing or crying. Preterm babies may not have a big, loud cry, and it is the breathing effort which is going to, you will take a decision based on that. So as I said, thank you, Rashna, Shashidhar, Seema, Suksham, Meena Joshi, Mayank were not able to join, and I think Ankita from Karnataka, Bangalore. There was another.
I think Priyanka is not.
Priyanka again from Karnataka. All of you have been great help in steering the group for week 2. So may I ask Lallan to say a few words before we wind up?
Thank you, sir. Thank you very much. I must thank all the faculty for taking out their time. Sridhar, one question from you. Can I ask, sir?
Sure.
So suppose after giving 4 to 5 breaths, and you have to check the heart rate. If heart rate is not rising, you said that then you have to start the MR SOPA. So if heart rate is not rising, then we have to see the chest rise. If chest rise is also not rising, then only we have to do the MR SOPA.
Yes, definitely. You're right. So whenever there is no heart rate, yeah, I apologize if I conveyed the wrong message. So initially, check the heart rate. No heart rate rise, check chest rise. If there is chest rise, then it's MR SOPA. You need not do. We just continue the background.
Thank you. Once again, thank all the faculty and sir for taking this initiative. I think most of the nurses has been benefited by this course. Once again, thanks all, and especially Dr. Pratima.
Yeah, thank you, sir.
Pratima and Puneet,
And Puneet, sir, yes.
And that reminds me, while I was saying delayed cord clamping, I mentioned it takes care of sugar, not sugar. Sugar is with immediate skin to skin care. The sugar levels are normal and the temperature is normal. Okay. So thank you, Lallan, coming and joining in a short notice. Thank you so much. Thank you. So we'll move to week 3 from tomorrow. And thank you once again, everyone.
Thank you, sir.